there are three so-called emerging treatments. One of them is momelotinib, and the promise of this drug was that it would not cause the same degree of anemia as ruxolitinib, and that it actually could make patients transfusion independent. So far, the only data, and data were presented there from the Mayo Clinic, but this was a 6-year follow-up on an initial investigator-initiated study. There haven't been any newer studies. The problem was claimed in that study was that there was peripheral neuropathy, which has been seen before with nonspecific JAK2 inhibitors. And the company recently found that they could not show that momelotinib was superior to ruxolitinib. So at this point in time, to my knowledge, the direction that momelotinib is going on with respect to possible entry into the clinical market is unclear. The other drug that has been of interest is pacritinib. Now, pacritinib is not solely a JAK2 inhibitor. It inhibits FLT3, it inhibits the CSF1R receptor, and an IRAK1. So it's more nonspecific. And the promise of this was that it could be given to patients who had platelet counts less than 100,000. And as you know, the FDA has sort of prescribed ruxolitinib first from being given to patients with a platelet count under 100,000, and more recently under 50,000. And I'm not sure what the basis of this was, except perhaps the idea of giving an ambulatory drug to a patient that's going to cause thrombocytopenia is not a good idea. On the other hand, if you don't treat the patient, the thrombocytopenia is not going to go away. And we've shown that when you treat patients with ruxolitinib, you can actually watch the platelet count go up. And of course, if you need platelets, that's an available therapy to temporize. At any rate, pacritinib was held off from the market because of an increased incidence, ironically, of thrombocytopenic bleeding and unexplained death and cardiac toxicity. So at this meeting, there was, I think, PERSIST-2, a phase 3 open-label trial of pacritinib against best available therapy, which in this case included ruxolitinib. And pacritinib did well in terms of the standard criteria of reducing spleen size and alleviating symptoms related to the disease. But at the end of the day, the thrombocytopenic bleeding was really not different. It may have been increased compared to best available therapy. And at this time, still, the FDA has a hold on the drug. So its future is unclear. And I guess my own personal feeling is we have two good therapies at the moment that we know a lot about. And while it's important to keep looking for improved therapies or different therapies, we ought to spend more time trying to figure out how best to use, together or alone, interferon, pegylated interferon, and ruxolitinib. And again, I should mention with ruxolitinib, there is the problem, do mutations prevent the drug from acting as it should? And again, there is controversy over this. So my feeling that the response 2 study is out, and in polycythemia vera patients without splenomegaly or myelofibrosis, ruxolitinib was superior to best available therapy. So I think the referendum is over on hydroxyurea. It should not be given to any patient unless there's a definite need for it, because we have now 2 better drugs. The question is, how do these drugs get used? I do want to mention there was one other drug therapy that is novel, and it's a drug called sotatercept, which is other name is ACE11. This is an inhibitor of TGF-beta proteins, and it was initially introduced to inhibit bone reabsorption. And when given to a patient with osteoporosis, her red cell count shot up quickly. In fact, almost too quickly to think that there's an erythropoietin-driven mechanism here. So there was a clinical trial of this. It's a drug that has to be injected. It's given 3 times a week, every 3 weeks subcutaneously. And there are 36% of the patients studied had a response to this drug, and if it was continually given, in some of these patients this was a durable response, they were all women. And this has been unique to this drug, that it's so far only the women that have responded, and I doubt if you keep giving it that you're going to see men respond. The mechanism is unclear, but it is something that, and it was tried in patients with myelofibrosis, is probably worth looking into to see exactly what it is doing, which we don't know at the moment.